Today, we're going to focus on something very simple, plain radiographs of the shoulder, not MRI, not CT, just plain films. Despite everything we do with advanced imaging, the majority of shoulder trauma and degenerative disease is first evaluated with conventional radiography. Most diagnostic errors do not happen because the modality is insufficient. They happen because the projection is inadequate or because the interpretation is unstructured. We'll proceed in a proximal to distal manner, beginning with the clavicle and periclavicular joints, then moving through glenohumeral instability, proximal humerus fractures, and finally, degenerative and systemic patterns. The emphasis today is not classification systems for their own sake. It is a practical interpretation, alignment, displacement, instability, secondary signs. What changes management? If you leave with one thing, it should be this: a disciplined, repeatable framework for reading shoulder radiographs so that nothing important is missed, especially posterior dislocation, glenoid rim fractures, and cuff insufficiency. Let's begin with projection accuracy. This lecture follows the structure outlined in Resnick Chapter 2, Physical Injury, Upper Extremity. Routine radiographic findings are emphasized. Although CT and MR imaging are fundamental in assessing internal derangements and complications, conventional radiographs remain the primary tool for evaluating fractures and dislocations of the upper extremities. We proceed in a proximal to distal direction, beginning with the clavicle and periarticular joints, then moving on to the glenohumeral joint. The osseous framework of the shoulder consists of the scapula, proximal humerus, and clavicle. On plain radiographs, we must consistently identify the humeral head, greater and lesser tuberosities, anatomical neck, surgical neck, glenoid fossa, scapular spine, acromion, coracoid process, and distal clavicle. The glenoid is shallow and relies heavily on soft tissue stabilization. The humeral head is retroverted approximately 20 to 30 degrees relative to the distal humerus, a key point when evaluating alignment. The acromion and coracoid form the superior and anterior osseous boundaries of the joint. The clavicle acts as a strut, maintaining lateral positioning of the scapula. Every shoulder radiograph must include a deliberate inspection of these structures before focusing on pathology. The glenohumeral joint is a ball and socket joint articulation between the humeral head and the glenoid fossa. The glenoid labrum deepens the socket and increases stability. Radiographically, alignment is best assessed on the axillary projection. The humeral head should be centered on the glenoid without anterior or posterior translation. The capsule attaches medially to the glenoid rim and laterally to the anatomic neck of the humerus. Capsular laxity or tearing is not visible directly on radiographs, but may be inferred from instability patterns or associated bone injuries, such as Hill-Sachs or Bankart lesions. Failure to access centering on the axillary view is a common reporting error. The acromioclavicular joint is a diarthrodial joint between the distal clavicle and acromion. Stability is provided by the acromioclavicular capsule and the coracoclavicular ligaments, which consist of the conoid and trapezoid components. The acromioclavicular joint has a small meniscus as well. This is an important test question. Radiographically, the acromioclavicular joint should be symmetric and aligned. The corticoclavicular distance must be assessed when evaluating suspected separation. Degenerative changes at the AC joint are extremely common and should not be overcalled unless clinically relevant. However, widening or vertical displacement requires careful measurement and documentation. The rotator cuff consists of supraspinatus, infraspinatus, teres minor, and subscapularis muscles. These muscles form a dynamic stabilizing envelope around the humeral head. The supraspinatus inserts on the superior facet of the greater tuberosity and is most commonly involved in degenerative tearing. Subscapularis muscle inserts on the lesser tuberosity and stabilizes anterior translation. On radiographs, we do not see tendons directly. Instead, we look for secondary signs: narrowing of the acromiohumeral interval, superior migration of the humeral head, greater tuberosity sclerosis, and cystic change. Understanding force couples explains why disruption leads to abnormal humeral head elevation. The scapulothoracic articulation between the scapula and the thorax is not a true synovial joint, but a functional articulation between the scapula and thoracic cage. Normal shoulder elevation requires coordinated scapular upward rotation and posterior tilt. The serratus anterior and trapezius muscles are essential for stable scapular motion. Dysfunction may lead to scapular widening, altered biomechanics, and secondary impingement patterns. On radiographs, scapular positioning affects interpretation of alignment and acromiomorphology. Malrotation can simulate or obscure pathology. Projection adequacy must therefore be assessed before interpreting structural abnormalities. Now we move forward into the key features of upper extremity trauma. The majority of fractures of the upper extremity are adequately evaluated with plain radiography. Specialized projections are particularly useful in regions of complex anatomy such as the shoulder. Because of the wide range of mobility at the shoulder is vulnerable to characteristic instability patterns. Advanced imaging plays an important role in classification and delayed complications, but plain films establish the diagnosis in most acute cases. Projection adequacy is fundamental. A complete shoulder series requires a true AP aligned parallel to the glenoid. An axillary view to confirm alignment. Without an axillary view, posterior instability cannot be excluded. And finally, a scapular Y view. Clavicular fractures are common. The clavicle is divided into distal 25 to 30%, intermediate 40 to 50%, and medial 25% segments. Most fractures involve the intermediate or central segment. Location and displacement determine stability and prognosis. An angulated fracture of the clavicle, as seen here demonstrated by the arrow, is shown in a skeletally immature child. Note the typical superior apex angulation seen with mid-clavicular fractures. Mid-shaft fractures typically show superior apex angulation. The medial fragment is elevated by the sternocleidomastoid muscle. The lateral fragment is depressed by the weight of the arm and pulled medially by the pectoralis major and latissimus dorsi. Cranially angulated AP projections better demonstrate comminution and displacement. In this radiograph, the upper image, a frontal radiograph of the right clavicle, demonstrates the typical fracture configuration of a displaced mid-shaft clavicular fracture. Note that the medial portion of the clavicle, indicated by the arrow, is pulled upward by the sternocleidomastoid muscle. The lateral portion, indicated by the asterisk, is pulled downward by the weight of the arm and inward by the pectoralis major and latissimus dorsi muscles. The lower image is cranially angulated view. Better demonstrates the fracture comminution and displacement. Distal clavicle fractures are classified according to their relationship to the corticoclavicular ligaments. When these ligaments are disrupted, the proximal fragment migrates superiorly. This image demonstrates elevation and skin tenting. These injuries are unstable. Medial clavicle fractures are uncommon, accounting for only a small percentage of clavicular injuries. They may be extra-articular or extend into the sternoclavicular joint. The critical issue is displacement. Posterior displacement places the subclavian vessels, brachiocephalic vein, and trachea, esophagus, and brachial plexus at risk. Patients may present with dysphagia, dyspnea, venous congestion, or neurologic symptoms. Plain radiographs are often inadequate because of overlapping medial structures. If there is clinical suspicion of posterior displacement or if the medial fragment is not clearly visualized, CT is a mandatory study. CT defines fracture morphology, joint involvement, and the relationship of the fragment to mediastinal structures. Any posteriorly displaced medial clavicular fracture should be treated as a potentially unstable injury, requiring urgent orthopedic and often thoracic surgical evaluation. If you cannot clearly see the medial clavicle on radiographs, do not assume it is normal. In this location, the undercost of calling the injury is very high. Acromioclavicular injuries result from a direct blow to the lateral shoulder, forcing the acromion downward relative to the clavicle. The severity reflects progressive ligament failure. Type 1 is a sprain without displacement. Type 2 disrupts the AC capsule with mild joint widening but intact corticoclavicular ligaments. Type 3 disrupts both AC and corticoclavicular ligaments, producing superior clavicular displacement and increased corticoclavicular distance. Types 4 through 6 are unstable injuries. Type 4 displaces posteriorly into the trapezius. Type 5 shows marked superior displacement with fascial disruption. Type 6 injury is rare and displaces inferiorly beneath the coracoid or acromion. On radiographs, assess alignment and measure the corticoclavicular interval. Compare with the opposite side when possible. Types 1 and 2 are treated conservatively. Type 3 is debated. Types 4 through 6 usually require surgery. Type 3 injuries demonstrate elevation of the clavicle due to disruption of both the AC joint and the CC ligaments. Compare corticoclavicular distance bilaterally on AP radiographs. Observe the superior displacement of the left clavicle with respect to the acromion on a lateral acromioclavicular view done upright with weights. The inferior margins of the clavicle and the acromion noted by the arrowheads are no longer aligned. Widening of the acromioclavicular joint and an increased distance between the clavicle and the coracoprocess indicated by the asterisk are apparent. The contralateral right side shows the normal relationships of these structures. Post-traumatic osteolysis of the distal clavicle may follow acute injury or repetitive stress. The key radiographic feature is progressive cortical resorption at the distal clavicle, leading to tapering and widening of the AC joint. The acromial cortex remains intact. The process may evolve over 12 to 18 months. In subacute cases, mild superior displacement may persist from the original ligamentous injury. This pattern must not be mistaken for inflammatory arthritis or for infection. In osteolysis, the abnormality is centered on the distal clavicle, without erosive change of the acromion and without periarticular osteopenia or soft tissue swelling, typical of inflammatory disease. If you see distal clavicular resorption after trauma, say it clearly. Findings consistent with post-traumatic distal clavicular osteolysis. Do not hedge with erosive changes that creates unnecessary rheumatologic referrals. Even under normal circumstances, the glenohumeral joint is relatively unstable. Its large range of motion comes at the cost of stability. Dislocations are classified according to the direction of humeral head displacement relative to the glenoid. Anterior dislocations are by far the most common. Posterior dislocations are less frequent but frequently are missed. Inferior dislocations are very rare. And finally, an unusual dislocation that is rarely seen but may be asked on exams. Luxatio erecta is an inferior shoulder dislocation with the arm locked overhead in abduction and a significant risk of neurovascular compromise. Remember, the age of the patient matters. Younger patients more often sustain instability associated with labral or ligamentous injury, whereas older patients more commonly sustain associated fractures of the proximal humerus. Your first responsibility with any trauma radiograph is checking the alignment. Before analyzing fracture patterns, confirm whether the humeral head is centered on the glenoid. The image on the left demonstrates a normal shoulder. The right image demonstrates a classic anterior dislocation of the shoulder on an AP radiograph. Dislocations are classified by the direction of humeral head displacement relative to the glenoid, and the associated injury patterns varies with age. Before we analyze instability, fix normal alignment in your mind. On the AP view, the humeral head should appear symmetric and centered on the glenoid, without medialization or inferior sag. The joint space should be uniform, and the head should not appear internally locked or excessively rounded. On the scapular Y view, the humeral head must project directly over the intersection of the Y, the meeting point of the scapular body, coracoid, and spine. If the head is not centered at junction, then think dislocation. On the axillary view, the humeral head should sit directly over the glenoid face. This is the critical projection that prevents missed posterior dislocations. Instability is simply the loss of this centering. Anterior dislocation is the most common form of glenohumeral instability and accounts for the vast majority of traumatic shoulder dislocations. On the AP view, the humeral head is displaced medially and inferiorly, typically positioned beneath the coracoid process in a subcoracoid location. The symmetric contour seen on the normal alignment slide is lost. On the scapular Y view, the humeral head is no longer overlies the center of the Y. Instead, it projects anterior to the glenoid, toward the coracoid, confirming the direction of displacement. The axillary view, when obtainable, demonstrates anterior translation relative to the glenoid face and removes diagnostic ambiguity. Always evaluate for associated injuries. Look specifically for a Hill-Sachs impaction defect of the posterolateral humeral head and a bony Bankart fracture of the anterior inferior glenoid rim. Anterior instability follows a recognizable pattern. Train yourself to identify it immediately. A Hill-Sachs lesion is an impaction defect of the posterolateral humeral head caused by contact with the anterior inferior glenoid rim during anterior dislocation. On plain radiographs, it is best appreciated on the AP internal rotation view. Internal rotation profiles the posterolateral humeral head and makes the cortical depression more conspicuous. Look for a subtle flattening of or cortical step-off along the posterolateral articular surface. In smaller lesions, it may appear only as a faint cortical irregularity. The presence of a Hill-Sachs lesion confirms prior anterior instability, even if the joint is currently reduced. Posterior dislocation is less common than anterior instability, but far more likely to be missed. It classically follows seizures or electrical injury due to violent internal rotational forces. On the AP view, the humeral head may appear symmetrically rounded, the so-called light bulb sign, because the arm is locked in internal rotation. The glenohumeral joint space may appear widened, producing the rim sign. These findings can be subtle. Is this image normal? The scapular view may suggest posterior displacement, but the axillary view is definitive. If you do not have an axillary view, you cannot confidently exclude posterior dislocation. Luxatio erecta is an inferior glenohumeral dislocation. The humeral head lies below the glenoid, and the arm is fixed in marked abduction, often held overhead. The mechanism is forceful hyperabduction, leveraging the humeral head against the acromion and driving the head inferiorly. Neurovascular injury is common, particularly involving the axillary nerve. Vascular compromise must be excluded. Associated fractures, especially of the greater tuberosity, are frequent. Radiographically, the humeral shaft appears nearly vertical, with the humeral head positioned inferior to the glenoid. This is uncommon but unmistakable. Recognize it immediately and document neurovascular status. A reverse Hill-Sachs lesion is an impaction fracture of the anteromedial humeral head caused by engagement with the posterior glenoid rim during posterior shoulder dislocation. On the AP radiograph, the finding is often subtle. Focus on the medial contour of the humeral head. Look for a vertical cortical density, the trough line, or abrupt flattening of the medial articular surface. Because the arm is typically fixed in internal rotation, the anteromedial defect may project more prominently than expected. Do not be reassured by apparent reduction. Glenohumeral alignment may appear normal at the time of imaging. The presence of this defect confirms prior posterior instability. As with the classic Hill-Sachs lesion, defect size influences management. A fracture of the anterior glenoid rim, a bony Bankart lesion, is a key instability-associated injury. It represents osseous avulsion at the anteroinferior glenoid following anterior dislocation. On the AP view, the finding may be very subtle. Look for a loss of the normal smooth anterior glenoid curvature or a small cortical fragment adjacent to the rim. Even minimal flattening should raise suspicion in the appropriate clinical setting. The axillary view is the most sensitive radiographic projection for detection because it profiles the anterior and posterior glenoid margins directly. If there is concern for bone loss, CT is appropriate for quantification, as the degree of glenoid deficiency influences surgical planning. Your responsibility is to recognize contour abnormality early. Missed glenoid bone loss leads to recurrent instability and failed repair. When assessing glenohumeral instability, the evaluation must follow a strict sequence. First, confirm that the humeral head is centered on the glenoid. Any asymmetry suggests subluxation or dislocation. Second, determine the direction of displacement. Anterior is common, posterior is frequently missed. Third, evaluate the humeral head for impaction defects, including a posterolateral Hill-Sachs lesion or an anteromedial reverse Hill-Sachs lesion. Fourth, inspect both the anterior and posterior glenoid rims for fracture or bone loss. Even subtle contour irregularity may indicate a bony Bankart lesion. Finally, insist on an axillary projection. Without it, posterior instability cannot be confidently excluded. A structured sequential approach prevents missed injuries. Proximal humerus fractures are common, particularly in older patients after low energy falls. In younger individuals, higher energy trauma is more typical. Evaluation must begin with glenohumeral alignment. Confirm the humeral head remains centered relative to the glenoid. Next, define the fracture pattern. Is this an isolated surgical neck fracture, a greater tuberosity fracture, or a multi-part injury? Assess displacement carefully, especially of the greater tuberosity and the medial calcar. Loss of medial support increases the risk of varus collapse. In elderly patients, associated rotator cuff pathology is common and influences management. Age affects both fracture morphology and treatment decisions. Surgical neck fractures are the most common proximal humerus injury. The fracture occurs distal to the greater and lesser tuberosities. Begin by confirming that the humeral head remains centered relative to the glenoid. Then assess angulation and translation. Varus tilt of the humeral head is common. Carefully evaluate medial cortical continuity as loss of the medial hinge increases instability. Displacement determines management. Fracture and dislocation may coexist, so alignment must always be assessed first. Anatomic neck fractures occur at the articular margin, separating the humeral head from the tuberosities and the shaft. Unlike surgical neck fractures, these directly threaten the humeral head blood supply, particularly the ascending branch of the anterior circumflex humeral artery. That is why the risk of osteonecrosis is substantially higher. On AP projection, the fracture may be subtle. Look carefully for a thin cortical break or step-off along the articular margin. Loss of the smooth subchondral arc is often the only clue. Displacement may be minimal, but even small separation is clinically important. Because this fracture is intra-articular, CT is commonly required to assess fragment separation, rotation, and humeral head viability. Greater tuberosity fractures are frequently subtle, especially on neutral or internal rotation views. In these projections, the fragment may overlap the humeral head and be easily missed. External rotation views are critical. They profile the greater tuberosity laterally and make small cortical step-offs or erosion or avulsion fragments more conspicuous. These fractures commonly accompany anterior glenohumeral dislocation. Whether you see a dislocation, actively search for a tuberosity fragment. Displacement greater than approximately 5 millimeters is clinically significant because it alters rotator cuff biomechanics and may require surgical consideration. Finally, distinguish an acute fracture from chronic degenerative sclerosis at the tuberosity. Acute injury produces cortical disruption and sharp fragment margins. Chronic change produces smooth sclerosis without a discrete fracture line. Lesser tuberosity fractures are uncommon and most often are associated with posterior glenohumeral dislocation. If you are thinking posterior instability, you must think lesser tuberosity. The axillary projection shown here on the lower right is essential. On standard AP views, these fractures can be completely obscured. The axillary view profiles the anterior humeral head and allows you to see small displaced fragments. Look specifically for a small medial avulsion fragment at the insertion of the subscapularis tendon. It may be subtle, just a sliver of bone displaced medially. These injuries are frequently overlooked. A structured search pattern prevents that mistake. If you see posterior dislocation, actively interrogate the lesser tuberosity before you move on. Multipart fractures involve the surgical neck and one or both tuberosities. Instability increases as more segments are displaced. Describe each fracture individually: head, shaft, greater and lesser tuberosities. Radiographs will define alignment. CT clarifies comminution when needed. These examples illustrate 2, 3, and 4-part patterns in the near classification. This is a varus-impacted proximal humerus fracture. The humeral head is tilted medially relative to the shaft. Notice the reduced head-shaft angle. In a normal shoulder, the angle is approximately 130 to 140 degrees. Here, it is clearly decreased, suggesting varus alignment. Observe the medial cortex. The calcar region is compressed and the medial support is compromised. Loss of medial hinge integrity increases the risk of progressive varus collapse and malunion. Glenohumeral alignment remains preserved, so this is not a fracture dislocation. Always describe angulation and medial cortical continuity explicitly in your report. Fractures involving the anatomic neck or significant displacement increase the risk of osteonecrosis. Although AVN is not visible initially, fracture configuration predicts risk. Follow-up imaging may demonstrate sclerosis, collapse, or articular irregularity. This is a displaced anatomic neck fracture dislocation in a 23-year-old man following a motorcycle crash. The AP radiograph on the left shows comminution involving the surgical neck, greater tuberosity and lesser tuberosity, with antero-inferior dislocation of the anatomic neck. Importantly, there is no measurable medial metaphyseal cortex attached to the head. The medial segment is less than 8 millimeters and displaced more than 2 millimeters, both strong predictors of avascular necrosis. 1 year later, despite internal fixation, follow-up imaging demonstrates sclerosis and collapse of the humeral head, confirming the presence of avascular necrosis. First, confirm glenohumeral alignment. A fracture description is meaningless if the joint is dislocated. Second, define the fracture location precisely: surgical neck, anatomic neck, greater or lesser tuberosity, or head split component. Third, describe displacement and angulation in measurable terms. Avoid vague language. Assess tuberosity involvement separately because even small displacement can alter rotator cuff mechanics. Finally, recognize patterns associated with vascular compromise, particularly anatomic neck fractures and complex four-part injuries. Glenohumeral osteoarthritis is best evaluated on a true AP or Grashy projection. Without a proper projection, joint space assessment is unreliable. Inferior humeral head osteophytes are often the earliest radiographic sign, sometimes visible before definitive joint space narrowing. Look carefully along the inferior articular margin. Always confirm projection accuracy before diagnosing narrowing. Malrotation can falsely simulate asymmetric joint space loss. When available, compare with the contralateral side. Subtle asymmetry becomes much clearer with direct comparison. The acromiohumeral interval reflects rotator cuff integrity. Normal distance is approximately 7 to 14 millimeters on a properly positioned AP radiograph. This space is necessary because the lateral aspect of the supraspinatus muscle and tendon live in this interval, as well as the subacromial bursa. Superior migration of the humeral head suggests chronic cuff insufficiency and must not be dismissed as projectional. On this AP projection, the acromiohumeral interval is markedly reduced. The humeral head is migrated superiorly and is abutting the undersurface of the acromion. This finding reflects chronic rotator cuff insufficiency. Note the remodeling and sclerosis of the undersurface of the acromion, indicating a long-standing process. This should not be dismissed as projectional if the film is properly positioned. Orthopedic surgeons in some countries are using this to diagnose rotator cuff tear prior to surgery rather than ordering the more expensive magnetic resonance imaging. Cuff tear arthropathy represents advanced rotator cuff insufficiency with degenerative remodeling. Marked superior migration and osseous remodeling distinguish this form of primary osteoarthritis. This radiograph demonstrates cuff tear arthropathy. There is marked superior migration of the humeral head with near complete loss of the acromial interval. Note the remodeling of the undersurface of the acromion, acetabularization, and the rounding of the humeral head, femoralization. This pattern reflects chronic rotator cuff insufficiency with secondary degenerative change. It must be distinguished from primary osteoarthritis. Many orthopedic surgeons refer to this as end-stage shoulder. Calcium pyrophosphate deposition disease produces chondrocalcinosis, linear or punctate calcification within hyaline cartilage or fibrocartilage. In the shoulder, this most commonly involves the glenohumeral cartilage and the AC joint. Unlike hydroxyapatite deposition, which produces amorphous peritendinous calcification, CPPD is intracartilaginous. Degenerative change frequently coexist, but cartilage calcification distinguishes CPPD from primary osteoarthritis. Evaluate both joint margins carefully and inspect the labral region and AC cartilage for linear densities. CPPD is also associated with subchondral cyst formation and joint space narrowing, sometimes disproportionate to osteophyte formation. CPPD may also produce acute inflammatory episodes, but on radiographs, the key diagnostic feature remains the presence of chondrocalcinosis. Note the linear calcification within the articular cartilage. This is chondrocalcinosis. The density parallels the joint surface rather than forming an amorphous peritendinous mass. Degenerative changes may coexist, but the cartilage calcification distinguishes CPPD crystal deposition disease from primary osteoarthritis. Hydroxyapatite deposition disease produces dense amorphous cloud-like calcification within the rotator cuff tendons, most commonly the supraspinatus tendon near its insertion to the greater tuberosity of the humerus. Unlike CPPD crystal deposition disease, this finding is not linear, intracartilaginous calcification. The deposit is typically cloud-like, homogeneous, and well-defined during the formative phase. During the resorptive phase, it may appear ill-defined and fluffy, and patients are often acutely symptomatic. The location is peritendinous, not intraarticular. Recognizing this distinction prevents confusion with chondrocalcinosis or fracture fragments. This radiograph demonstrates hydroxyapatite deposition within the supraspinatus tendon. Note the dense, amorphous, cloud-like calcification adjacent to the greater tuberosity. The deposit is peri- or intratendinous rather than intracartilaginous. Unlike CPPD, this is not linear cartilage calcification. During the resorptive phase, these deposits may appear ill-defined and are often acutely painful. Inflammatory arthropathy, for example, rheumatoid arthritis of the shoulder, produces uniform joint space narrowing rather than focal inferior narrowing. Marginal erosions are common, particularly along the humeral head and glenoid margins. Periarticular osteopenia may be present. Unlike primary osteoarthritis, osteophytes are not the dominant feature. Bilateral involvement is frequent and should raise suspicion for systemic inflammatory disease such as rheumatoid arthritis. Always assess both the glenohumeral and acromioclavicular joints, as inflammatory patterns often involve multiple compartments. This radiograph demonstrates uniform glenohumeral joint space narrowing with marginal erosions and relative absence of dominant osteophytes. The pattern is diffuse rather than focal inferior narrowing. The bone appears relatively osteopenic. This constellation favors inflammatory arthropathy over primary osteoarthritis. Bilateral involvement should always be assessed as inflammatory disease is frequently symmetric. In ankylosing spondylitis, superolateral humeral head remodeling produces a sharpened contour, sometimes described as a hatchet appearance. Unlike primary osteoarthritis, large inferior osteophytes are not dominant. The contour change reflects inflammatory erosion and remodeling rather than osteophyte formation. Key findings are acromioclavicular joint ankylosis, erosions on the humeral head producing a hatchet-shaped deformity, and ossification of the corticoclavicular ligament, often indicating severe, long-standing disease. This radiograph demonstrates superior humeral head remodeling producing a sharpened contour, sometimes described as a hatchet appearance. Unlike primary osteoarthritis, large inferior osteophytes are not the dominant feature. The contour change reflects inflammatory remodeling and erosion in the setting of ankylosing spondylitis. Degenerative shoulder patterns must be differentiated systematically. Primary osteoarthritis is characterized by osteophyte formation and joint space narrowing, typically with preservation of humeral head alignment. In contrast, cuff tear arthropathy demonstrates superior migration of the humeral head with remodeling of the acromion and glenoid due to rotator cuff failure. Crystal deposition disease produces characteristic calcifications, which must be distinguished by morphology and location. Inflammatory arthropathy results in uniform joint space narrowing, marginal erosions, and bone loss rather than bone production. A structured pattern-based approach prevents misclassification and improves diagnostic accuracy. Most diagnostic errors in shoulder radiography are failures of pattern recognition rather than failures of knowledge. The most common error is failure to obtain or properly assess the axillary view in trauma, leading to missed posterior dislocation. Glenoid rim fractures are frequently subtle and easily overlooked. Superior migration of the humeral head may be dismissed as projectional rather than recognized as biomechanical failure. Cuff tear arthropathy is often misclassified as primary osteoarthritis. A disciplined search pattern prevents these errors. Alignment first, then fracture, then joint space, then bone margins. Every time. Posterior dislocations are missed in more than half of cases on initial assessment. Projection adequacy is fundamental. A non-true AP can falsely suggest joint space narrowing. Before diagnosing osteoarthritis, confirm that the glenoid is properly profiled. Internal rotation may obscure greater tuberosity fractures. If the tuberosity is not well profiled, small avulsion fragments will be missed. Without an axillary view, posterior instability cannot be excluded. That omission alone accounts for many missed dislocations. Overlap can simulate glenoid irregularity or articular defects. Before diagnosing pathology, confirm projection quality. Technical awareness is diagnostic awareness. Shoulder radiography is not about memorizing findings. It's about structure. Confirm projection adequacy first. Assess alignment second. Localize fractures precisely. Describe displacement clearly. Evaluate tuberosities separately. Recognize instability patterns. Differentiate degenerative, traumatic, and crystal-related diseases systematically. Most diagnostic errors in shoulder radiography are not due to complexity. They are due to omission. Structure prevents omission. That is the core principle. Thank you so much for your attention, and I hope you enjoyed this presentation.